A very good morning to all the senior dignitaries, delegates, and my colleagues. It gives me great pleasure to invite you all and welcome you all to the conference on assisted reproductive technology. An exciting day loaded with interesting topics and discussions lie ahead of us, which I'm sure all of you are eager to witness. Before proceeding any further, I would like to thank each and every one of you for joining us today by taking time off from your busy schedule. So let's proceed with the first session. I would like to invite the chairpersons for the first session. I request Dr. Vasundhara Tyagarajan ma'am to come on to the dais. Dr. Vasundhara Tyagarajan, she is a popular gynecologist, sonologist and IVF specialist, and she is the director at BM Hospital's New Life Fertility and IVF Center. She is running a fellowship course on reproductive medicine and fetal medicine, and she has been awarded the Best Doctor Award by the Tamil Nadu State IMA and IMA Chennai NAM branch, and she received the Lifetime Achievement Award by the Rotary Club in recognition of her service to humanity in the field of medicine. I welcome you, ma'am. Next, I'll introduce the next chairperson, Dr. Kundavi Shankar, ma'am. She is a HOD and senior consultant at IRM MMM, and she is a renowned national board certified obstetrician and gynecologist. She is a specialist in reproductive medicine and laparoscopic surgery for more than 20 years, and she has published many papers and in the renowned international and national journals. Next, I would like to welcome Dr. Jairani Kamraj ma'am onto the dais. Dr. Jairani Kamraj, she is a senior infertility specialist and director at Akash Fertility Center and Hospital. She has received many prestigious awards. She has been awarded the Women of the Year award by the Lions Club in 2010, and she received the Achievement of Yeoman Service Award by Exnora 2010, and she has received the Best Paper Award for Sexual Dysfunction in PCOS Infertile Women in AOFS 2016 in South Korea. Welcome you, ma'am, to the dais. So let's proceed with our first session. I request Dr. Vasundhara Tyagarajan ma'am to introduce our first speaker, Dr. Sonia Malik.
Hello. Good morning and happy smart morning. I am proud and thankful to the organizing committee of Smart 2020 for having given me this opportunity as chairperson for the opening session. My heartfelt thanks to Dr. Sanjeev Reddy sir always. All of us know that Sri Ramachandra Institute of Higher Education and Research is always proud to have the specialty course a decade ago. MCH Reproductive Medicine and Surgery was started first time in India and recognized by MCI. In this conference of ART, the delegates are going to have academic feast and they are going to enjoy it. Coming to the first topic in the first session, it's going to be the immunology in recurrent implantation failure by Dr. Sonia Malik. I invite Dr. Sonia Malik. Yeah.
Good morning, everyone. Good morning. First of all, many thanks and congratulations to Dr. Sanjeeva Reddy on this great conference and for the great achievement. We are, as Doctor has just mentioned, we are all very proud of him, and we know that this organization and this college really spells academics, and we are really proud to be associated with it. I am also thankful to him for giving me this opportunity and accommodating me to speak to you virtually on this conference where I was supposed to be present physically, but for certain reasons I could not come. Thank you very much, sir, for accommodating, and thank you, chairpersons, for this. Thank you, chairpersons. Can I start sharing my screen?
Yes, madam, you can share it.
So I dedicate this lecture of mine to our great teacher, Dr. P.N. Chakravarti, whom we lost very recently. As a subject, immunology was very dear to him, we all know. And probably most of us have learned a lot of immunology from him, from the various studies, various papers that he has published. So I dedicate this lecture to him. Sir, we are going to miss you at every conference, at every level. You were a great teacher, a great human being, and we shall all be missing you in the field of ART. Today, I shall be speaking upon immunology and recurrent implantation failure. And we all know what implantation failure means, because now more and more of implantation failure is coming to us in our day-to-day practice. We have these repeated failures coming to us every day. And all along, we have been thinking about the embryo being a part of this, but now the stance has also changed to the endometrium, where we are trying to look at the endometrial receptivity, which could be a limiting factor in pregnancy. And we know that even when we transfer good euploid embryos into the endometrium, pregnancy still does not happen. So there have been many manifestations of endometrial asynchrony that have been described. There have been variations in the histology, the steroid receptors, the markers of implantation, gene profiling, and immune markers. What we need to understand is this puzzle. Are these all related, or are they separate from each other? Do they have an impact on each other, or are they just lying there separately trying to do their own functions? That is what we need to understand, and understand immunology in the perspective of histology, maybe, and in the perspective of other markers which we are all trying to study separately. So my diarist with immunology began in 1996, when I started looking at tuberculosis once I entered the field of IVF, and then in 2003 I published this paper on genital tuberculosis and its impact on implantation, where I was trying to think about immunology as the factor which is causing latent tuberculosis and hence causing this kind of a problem. We also presented a paper in 2004 where we looked at the cytokine profiles of the endometrium in patients of endometritis and presenting with recurrent pregnancy loss and unexplained infertility. And basically, we found that there was a high positivity of TNF alpha and interferon gamma in these patients, more in infertile patients than in patients of recurrent pregnancy loss. So then, this is when I started talking to Dr. Chakravarti about immunology, and we kept on interacting with each other. I was like Eklavya, following him all the time from distance. I never got the opportunity to work in his unit, but being interested in immunology, we kept interacting with each other. And this was one of his first papers, I wouldn't say first, but yes, in 2003, where he was systematically looking at all the cytokines that get disrupted in various conditions in the uterus. Latent tuberculosis being his favorite. And then this paper again appeared somewhere, talking about the microscopic contributions, and he looked at the microscopic biochemical markers of tuberculosis in the endometrium. And basically, as you can see, this group was looking at the various cytokines and what happens to them when the patient has tuberculosis. Similarly, the pinaport was also studied, and this entire study was funded by ICMR. And then we at the same time were looking at simpler things like CD138 plasma cells, or endometritis, which is present in the endometrium. So therefore, let me just summarize what has been happening. We have always been talking about autoimmunity, APLA, and thyroid in cases of immunology, but it has more to it. What about the hormones, the infections, the unexplained RIF? So let us just try and see if we can fit in this jigsaw puzzle and see whether they fit into each other, and one can lead to another. So we all understand the immune system very well now, with the COVID coming and telling us about it. We know that there is an innate immunity which is non-specific and has no memory. And then we have the upregulation of the adaptive immunity, wherein it is specific and has the ability to recognize the antigen by virtue of its having its memory. And this is cell-mediated and humoral. This is just a revision to tell you that once the infective agent or anything which is abnormal presents with a carbohydrate and protein structure, there is activation of the innate immunity, and finally with the antigen presentation and cytokine secretion and cell-to-cell interaction, activation of specific immunity. This is what happens to everyone in cases of the immune system. However, in pregnancy, we have two kinds of cells which are very, very important. One is the regulatory T cells, or the TREG cells as we call them, and the other is the dendritic cell, or the DCs, which are the antigen presenting cells. And between the two cells, there is upregulation and downregulation of the immune response, which is happening at the interface between the embryo and the mother, and at the placental site. And that is what is important for us to understand, that these TREG cells control the immune response and then downregulate the inflammatory response. And the dendritic cells, which act as the antigen presenting cells, they play a critical role in the adaptation of the immune response and can modulate the lymphocyte polarization to potentially destructive or protective, that is the Th1 response or the Th2 response, which we are very familiar with. So therefore, these two cells definitely need to be looked into. But then there are a lot of factors which are going to regulate the immune system. And if you can see over here, it starts from human genetics, endocrinology, cytokine profile, route of infection, previous infections, presence of other infections, pathogen load and pathogen strain. So all these features are actually going to affect the immune regulation within the body of the person. And three hypotheses have been proposed all along. The first one was by Peter Medavar, and we all know it, and that has actually formed the basis of transplant medicine, which suggested that the fetus is an allograft, and basically it is the downregulation of the maternal immune system by the fetus which is actually causing all this, which is allowing it to implant inside the mother's womb. And then in 1980, Tom Wegman actually put forward the Th1, Th2 response or hypothesis, which we are all familiar with. And it was basically this, according to this hypothesis, the cells were categorized into Th1 cells, which produce the inflammatory cytokines, or the Th2 cells, which produce the anti-inflammatory cytokines. However, the recent studies have clearly demonstrated that there is an active immune tolerance and adaptive immune system which must exist at implantation. And as I said, it is the T cells, which are a special subset of cells that are actually important and regulate the inflammation at the site. So basically, these cells are influencing all the other cells, the dendritic cells, the NK cells, and other cells that we talk about when we are talking about immunology of pregnancy. But what is the influence of estrogens on these T cells? How do the hormones affect them? If you can see over here, the Th1, Th2 response on the TREG cells is also influenced by the estrogens, which actually stimulate these naive cells to produce the cells that we are talking about, the T cells. And depending upon what amount of estrogen is there in the body, the various cells are actually activated. This is a beautiful paper which appeared in 2007, which tells us that estrogen levels in the body actually regulate the cytokine secretion differently. The green green indicates the stimulation of these cells, and the orange denotes the inhibition by E2. So therefore, you can see over here that during pregnancy, there is the upregulation of these cells, which is cytokines, which is happening, and there is an inhibition of the TNF alpha and so other cells, thereby decreasing the inflammation at the site of implantation, depending upon the levels of estrogen. Similarly, in the postmenopausal woman, these cells are actually different, and therefore the cytokines also are differently stimulated. This is very interesting because it tells us that if the estrogen content in the body is not proper, then the immune system is also going to be affected. Similarly, what is the role of progesterone? Again, progesterone induces maternal fetal, it acts at the maternal fetal interface, and actually is responsible for the upregulation and activation of these cells, and therefore it produces tolerance again at the same site. So hence, there is a huge role which is being played by the hormones, and it is the interplay of the hormones and the immune system which is actually causing what is happening over there. So the endocrine regulation of the immune response is actually very important. So if you have a high estrogen and progesterone content, only then are you going to get that Th2 response that you have been talking about all these years. And then only these cytokines which are friendly to implantation are going to happen. But if the estrogen content is not proper, or maybe the progesterone also is not proper, then you are going to have a Th1 dominance, and the cytokines are also going to be different. So therefore, the immune system is definitely regulated by the hormones that we have in the body. And these are some of the functions which are produced, or the hormonal effects that are produced upon the immune system. And estrogen, as you can see, is causing a lot of change in the cytokines as well as the immune systems, immune cells, so also progesterone. So the key concepts are that both the mother and fetus contribute to it, all, and most importantly, it depends upon the ovarian steroid hormones, and these are initiated prior to and concurrently with the implantation. This is something that we need to understand and we need to follow much more closely now. So look at the diseases that we see day to day, and in all these diseases, you find that there is abnormal cytokine response that we get over here. And why does this happen? We all know that the hormonal milieu in these conditions is also abnormal. Hence, the cytokine profiles in these conditions would definitely be abnormal. So it is not that we have to just correct the cytokine profiles and in order to get a better response or a better outcome in these patients, we need to correct the hormonal response also in order to have a totally normal milieu over there for implantation. So what the challenge, of course, is that the hormonal milieu in pregnancy keeps changing. It is a pro-inflammatory environment when the implantation is taking place. Then during mid-pregnancy, it becomes a little more quieter and an anti-inflammatory milieu starts. And again, a pro-inflammatory environment takes place in the third trimester and at the end of pregnancy, so that delivery can take place, so that expulsion can take place. So there is a waxing and waning of the type of response that we have in pregnancy, right from the beginning to the end, and therefore the cytokine profiles also keeps on changing as the hormone profile changes. Coming to the second part of it, that is infection. Now, like I said, we were talking about about these infections for a long time, and I was concentrating only on tuberculosis. We found that in 23% of cases of failed IVF have chronic endometritis in our series, and this paper won the first prize in this conference. So, but when we look at the vaginal microbiome and look at the pregnancy rate, now that we are talking about vaginal microbiome all the time, we find that the patients who have a high lactobacillus content have a better profile, better pregnancy outcome as compared to the others. So therefore, even the microbiome is somehow affecting the pregnancy outcome. And this paper in 2008 actually told us that it is also the ovarian stimulation which is affecting the vaginal microbiome. So therefore, it is, ultimately, whatever we see inside the tract is definitely going to be influenced by the hormones that we are producing in the body. So hormone-dependent microbial shifts may have a bearing on the pregnancy outcome. This was what was found in 2008 in this paper, and lactobacillus is supposed to be favoring this. So therefore, when this paper talks about the 2019, they talk about the effect or the cyclic hormonal changes not only in the immune cells but also in the microbiome. So if you can see what is happening over here, during the estrogenic phase, the cytokines are different and the microbiome is also different. Whereas when progesterone comes into the body, the cytokines change, the pattern changes, and also the microbiome pattern also changes. But like I said, it is definitely better. The outcomes are definitely better if the hormones are right, the microbiome is right, the immune cells are right. So everything is connected to each other. Therefore, when we have to actually solve this jigsaw puzzle, we have to think of all these things when we are thinking about recurrent implantation. And how did they find this? This is a very nice study which again took place in 2008 when they were trying to find out what happens to HIV. And what they found is that the window of vulnerability was actually mid-cycle when implantation takes place, when the immune system is down-regulated completely. That is when these dormant infections get upregulated and they start manifesting at that time. So this is the most vulnerable period, not only for HIV, we also know it is for tuberculosis and other such infections. And therefore, the window of implantation is the time period also when the uterus is ready to accept the fetus, accept the embryo, and that is also the time when these opportunist infections find the environment conducive to become active. So, how do we investigate such patients? We have to lay a great stress on the history, and of course, we are doing the applied thyroid profile. The histopathology also, like I said, will tell you a lot because basically it tells you about the hormonal profile at the endometrial level, the endometrial receptivity array, and should we be doing the uterine NK cells also, because these are the immune markers which have become quite fashionable and we keep talking about them all the time. I will not spend much time on these except the history, where you have a huge list of patients, failed cycles despite transfer of good embryos, PGS normal embryos, too early miscarriage before the heartbeat was detected, miscarriage after detection of the heartbeat, secondary infertilities, pregnancy loss, endometriosis under the age of 40, and unexplained poor egg and embryo quality, PCO or strong clinical symptoms of PCO, autoimmune disease, and early pregnancy loss, late complications. So these are the patients who will present to you with different kinds of history and different kinds of profile, thereby giving you an indication what could have gone wrong. Coming to ERA, we know that many a times there is an out of non-receptive ERA report that we receive, receptive and non-receptive. But I think there is more to ERA than we can see. And a shift in ERA may actually mean a lesser exposure to progesterone, a higher dose of progesterone which may be required, or estrogen was not sufficient to induce the progesterone receptors. This part is actually denied by the people who have come out with this test. They say that the follicular phase is absolutely normal and you don't have to consider it. But I think we may be wrong over there, and it is the follicular phase also which actually impacts what is happening in the window of implantation now that we know so much about immunology and other factors. So I think as a whole, ERA should be looked at again to see where we are going wrong when we are transferring good embryos, and the ERA is also in the receptive phase, and yet pregnancy does not take place. The NK cells. The uterine NK cells are a subpopulation with low cytotoxicity, and they are the predominant leukocyte fraction in the decidua. They are the master regulators of events which take place over here, and actually they are responsible for the remodeling of the spiral arterioles. So they have a low cytotoxicity, and they actually help in the implantation of the embryo. But when they are dysregulated, when they have a higher cytotoxicity, as you can see in this part of this picture, then there is no remodeling of the spiral arterioles, and that is what prevents the implantation from happening at this level. So should we be looking at the uterine NK cells also as a marker? Well, some of the reports that we see now, especially this one which has appeared in 2021, talks about what we should be doing and what we should not be doing in these patients. How should we test them? So they have looked at all the diagnostic guidelines of different associations, and they have explicitly said that chronic endometritis has been recommended in 2018 by all the European guidelines except ESHRE, where further studies are still recommended, and ASRM, of course, says that these cells should not be tested. But then, of course, this paper, on the other hand, suggests that there is a controversial evidence for dendritic cells and T regulatory cells, but therefore we should not be testing these things until and unless more proof comes in. However, chronic endometritis must be tested. What about the therapies that these guidelines are suggesting? Again, ESHRE and ASRM are totally against any kind of therapies from the immune point of view. But these other guidelines from Europe do say that glucocorticoids and allogenic therapies may be done, but not outside the studies that have come up already. So therefore, theirs is a guarded opinion about these therapies, but ESHRE and ASRM definitely say that immune therapy should not be offered routinely to these women. So, but then when we look at the papers, is there a difference between the RPL and RIF? Because RIF indicates a very, very early implantation failure, and RPL is happening a little later. So the immune abnormalities in the TREG cells are definitely different, and the uterine NK cells also behave different in the RIF patients as compared to the recurrent miscarriage patients. So these patients show not only differences in the immune cells, but also in anatomic risk factors. Fibroids being more prevalent in RIF, while the risk of adhesions is higher in recurrent miscarriages. The screening for an APLA, while not screening for other thrombophilia, for thyroid dysfunction and for parental genetic disorders, also shows difference between the two types of patients. So therefore, they are different entities, yet they are similar because we are looking at implantation, we are looking at failure of pregnancy. So the immune therapies that have been suggested for both are basically, as you all know, immunoglobulins and all these different practices that are being followed. They can be divided into two parts: the immunomodulatory therapies and the treatment enhancing endometrial receptivity, out of which we have talked about endometrial receptivity array, vaginal sildenafil, and intramuscular growth hormone are some of the therapies which we are also using, in addition to the others that we are using for immune modulation. This paper in 2021 is a meta-analysis of 22 RCTs and 19 observational studies, which tells us about the effectiveness of these therapies and interventions in repeated IVF embryo implantation or repeated IVF failures. And as you can see here from the forest plots of all of them, they are all suggesting that they are favorable. They are all suggesting IVIG, intrauterine HCG, PRP, all of them seem to be favorable. And also here, you can see over here, low molecular weight heparin and intravenous intralipid. Everything is towards this side of the forest plot and suggesting that these therapies do seem to be having some kind of an effect when the patient population is carefully selected. But what is happening is that the best outcome has actually come out of the intrauterine use of PBMC, which of course most of us are not using as yet in India, but also the subcutaneous GCSF rather than intrauterine GCSF. The best outcome has inferred out of this meta-analysis is for this molecule, is for this entity, and this seems to be giving the best results. All the other agents, although favorable, did not seem to have distinct benefits. Then coming to another very exciting paper is this one, which appeared from the French group in 2020, where 1,738 infertile patients had an immune profiling by means of an endometrial biopsy between 2012 and 2018. Part of this paper is yet to be, the final part is yet to come in, and probably at the end of 2022, the rest of it will come out. And they found that there is an definite endometrial immune dysregulation which was identified in these patients, and pregnancy rate was significantly higher if an endometrial dysregulation was found, and then a personalized plan which was applied compared to the patients with an apparent balanced immune profile. So what they did was, they targeted a personalized immune plan and suggested it to the clinician treating these patients. So this was a paper between the immunologists and the clinicians. So they did the profiling and suggested the treatment, and then said what was looked at the outcome. So this is a very exciting paper which talks about the pregnancy rate improving once the required treatment was given to these patients. So 16.5% showed no endometrial immune dysregulation, 28% had a local immune underactivation, 45% had local immune overactivation, and 10.5% had a mixed endometrial profile. So all these patients had different entities which are suggested to them depending on which kind of profile they presented on endometrial biopsy, and then the patients were treated. So these new papers are quite exciting, and they do tell us that if we look at the endometrium and if we look at the hormonal milieu along with the immune milieu, then we are going to have a better outcome in these patients of recurrent implantation failure. And with that, I conclude saying that as science advances, we are getting to know the intricacies, and we are getting to know that endocrinology of the host also causes a lot of influence on these, and therefore corrective measures of the hormonal milieu will lead to better immune milieu also, and probably correct the immunological factors in recurrent implantation failure. Thank you very much for your attention.
Thank you, Doctor. Dr. Sonia Malik, she's a director in HOD, Nova Southern Fertility and IVF Center in New Delhi, and she has been awarded so many awards as IMA Kanak Koil Award 2007, Lifetime Achievement Award, Best Doctor Award, and ACE Lifetime Achievement Award, and Norab Jin Lifetime Achievement Award in 2019. And thank you very much, madam, for your excellent and informative talk. Being a Zoom, we want to finish the question answers from the audience now itself. So audience can ask questions.
When to start the GCSF for the recurrent pregnancy loss and how long it to continue? And second question is, what is the dosage of intrauterine HCG and when will you give and how long you will give?
Thank you for that. Thank you for those questions. GCSF, first of all, GCSF, there are the various studies have used GCSF differently. The intrauterine GCSF is used generally according to the physiology. When the cytokines are upregulated, they are upregulated only after the dominant follicle has come into, has grown up. So therefore, when you find that your endometrium has started to respond, if you are doing an FET cycle or if you are looking at a thin endometrium otherwise, then once the endometrium is beyond 6 millimeters, that is the time when you start giving the intrauterine GCSF. When you are giving the subcutaneous GCSF, again there are different protocols for that. But in this meta-analysis, the papers that I looked at for GCSF, they have started GCSF as early as the 3rd day of the menstrual cycle, and they are giving repeated doses every 4th day. So that is one protocol, but we have also given GCSF just 2 doses subcutaneous. Once the dominant follicle is visible, if you are doing a stimulated cycle, or when the endometrium is beyond 6 millimeter, that is for GCSF. HCG again, HCG has been used in larger doses, 200, 100 like that. But basically, if you can reduce the dose of HCG to minimal, that means 50 or maybe maximally 100, then it gives the best results. And it has to be done on day 3 post ovulation. That means day 3 embryo, before day 3 embryo transfer, or when you are going to transfer, that is the time that intrauterine HCG should be instilled, because that is the time HCG is upregulated in the system by the growing embryo. So that is how you you have to follow the physiology and start giving these things according to that. Then only you might get good results.
Thank you, madam. We'll close the first session, first talk.
Thank you very much.
We'll go for the next talk.
Chairperson. Thank you so much.
Thank you, ma'am.
Thank you so much.
We'll go to the next talk.
அனைவருக்கும் வணக்கம். Good morning, dear friends. It has been a happy morning, and I have a heartfelt wishes to Smart 2022 for achieving this 10-year of wonderful service and knowledge to the MCH. And I wish HOD, and who is the man behind it, Dr. Sanjeev Reddy, to celebrate 100 years with all his excellence, doing the best for the education. Thank you, sir, for giving us an opportunity to be a part of this wonderful ceremony. And I have the great pleasure and honor to introduce the dynamic, ever young, and a very dynamic women in Foxy, Dr. Nandita Palshetter, who is the president of IZAR and who is the FIGO elect a Foxy representative to FIGO, now elect, and who was a past president of Foxy 2019, and who is a president presently of AMOX, and the president of MOX, and she has been presided over all the other great societies, and who has done a wonderful, marvelous work in the field of IVF for the past 30 years. And I think everyone here and all over the country knows her. It's a very great pleasure to have you here, madam. And I would like you to present your presentation on recent advances in understanding management of PCOS, which is a very important topic for the practicing as well as the budding fertility specialist. Over to you, madam, to present your presentation on PCOS.
Thank you. Vanakkam. I think, first of all, congratulations, Dr. Sanjeeva Reddy. It's really an amazing job that you've done for the last 10 years and created this department, which is well respected throughout the country. And I think you're the first one to have DM and reproductive medicine, which today the government has actually recognized it, and it is one of the requirements that you can just start your practice straight off if you have DM and reproductive medicine. Otherwise, we as gynecologists need certain amount of experience and other factors which are needed, 50 OPUs, etc. So till the rules and regulations come of the ART law, we don't have much clarity. But as the law stands right now, anybody who has the experience of 3 years working in a reproductive medicine unit, a person who has done supervised 50 ovum pickups, and a person who has a DM in reproductive medicine or a fellowship in reproductive medicine can practice, can start an IVF center. So with that introduction, I'd like to go on. Today, I'm going to be talking about a very different topic, something different, obesity-related complications of PCOS syndrome and infertility. I'm going to cover it in different headings, like we're going to talk about disease, diagnosis, epidemiology, etc. And I'm going to be short and sweet and just go through the whole thing. So I think if you look at the disease of PCOS, infertility is the most common, infertility is the most common cause of female infertility. If you look at it, 40% of the women of PCOS have infertility. But look at the other side, 60% don't have infertility. We get a lot of adolescent girls who come to our clinics and say, will I be infertile? The mothers are really worried. I think you need to reassure them and tell them that if you do lifestyle interventions, if you change a lot of things about them, they may not suffer from infertility. So yes, hirsutism you do see in 70% of the women, irregular periods in 80 to 90% of the women, acne in about 33% of the women, oily skin is very commonly found, acanthosis nigrans in 50 to 60%, and PCO on the ultrasound in nearly 80% of the women. Diagnostic criteria has really changed over the years, from the NIH to the Rotterdam criteria to the Androgen Excess PCOS Society. And we know that from 1990 to 2003 to this different phenotypic classification of PCOS by Aziz in 2016, where he actually divided them into phenotype A, B, C, and D. And you can see in phenotype A, all the three characteristics are present: hyperandrogenism and hirsutism, ovulatory dysfunction, and PCOM, the polycystic ovarian morphology. In phenotype B, the PCOM is not present. In phenotype C, there's only hyperandrogenism and PCOM. And in phenotype D, there's no hyperandrogenism. And what is the relevance of all that? I think the most important thing that we need to remember is that the A is the one which the HOMA-IR, that means the AMH and the insulin resistance is the highest. And the B phenotype is the one which requires the higher doses of gonadotropins. So I think the clinical significance is coming out that way. But of course, a lot of treatment changes are going to happen as we progress further into different aspects of medicine, which I'm going to talk about. If you see the prevalence, if you took only the NIH criteria, only 6% of the women actually came under PCOS. And the Rotterdam and the Androgen Access Society actually widened the definition, and you found that nearly 4% of the women of the population, we had missed out into classifying them as PCO. And that is why there was the change in this. And if you see that even in normal and overweight, you do have overweight, normal and underweight patients who are PCOS, and the overweight patients are the one who have the maximum insulin resistance, the metabolic syndrome. But there are the lean patients also who suffer from it. And this meta-analysis, which was published in 2012, actually shows the risk ratio, which is the higher risk of PCOS with obesity. All these studies show that obesity, if it is there, the risk of PCO is much higher in these women. And that's why it is very frequently interchanged, that if you look at a person who is obese, you say, oh, she's PCOS. Or a PCOS woman, vice versa, of course, is true. But not all obese women are PCOS. So we must learn to differentiate. But basically, the therapy is somewhat similar. If you look at pathophysiology, it's the hypothalamo-pituitary axis which is deranged. We all know the GnRH pulsatility is changed, and the LH pulses which are there, they are more frequent, they are higher, they are not well spaced out, and that is because of that the FSH pulses go down, and all the different changes that occur in the ovary leading to anovulation, there's insulin resistance, there's obesity, there's hyperandrogenism, and all the side effects start because of that. But there are other factors also which contribute to it. Genetics is coming in a big way. I'm going to talk about it. There are lots of genes. It's a polygenic disease which has multiple genes, and the GWAS study which was done, genome-wide association which was done, which actually will give us, which will enlighten us about the causes of PCOS. So genetic predisposition is a big thing today. Hormonal imbalance, we know the increased androgens in 60 to 80% of the patients. Insulin levels are affected. There's insulin resistance in 50 to 80%, obesity in 60 to 80%, ovarian dysfunction in 70 to 80%, and hypothalamic pituitary abnormalities. And what does this all cause? See, we look at PCOS patients, we make them pregnant, and we send them away. I think the long-term risks of PCOS need to be tackled by us gynecologists, because finally we are here for the woman and we need to take care of her and keep her healthy. Fertility, subfertility, definitely yes, it is a priority because the woman comes to us for it. But there are a lot of things which she doesn't come to us for. And obstetric complications, I think we need to be, we need to have our antennas up. That this is a PCOS patient, and put her in the high-risk category and monitor for the obstetrical complications. The cardiovascular disease risk, the impaired glucose tolerance, the type 2 diabetes, the metabolic syndrome, then malignancies, and today what has really become very, very prominent is the psychological complications. I think we need to look at each of them and understand that our duty is not only to get her pregnant, but to take care of her so that she doesn't have the consequences of PCOS. This study, which was published in 2015, clearly shows that PCOS, definitely, if you see the first chart, the bar diagram, the PCOS patients have a higher chance of infertility as compared to the non-PCOS patient. And even as compared to the BMI, you can see the thinner patients and the PCOS and the non-PCOS. If you compare both with the BMI, the obese patients definitely have a higher chance of infertility. And also treatments. the treatment which they need is much higher in PCOS patients, obese patients, and that is why we need to look at it. Risk of primary ovulatory infertility is increased with obesity. You know, I was trying to find a study comparing PCOS, lean PCOS with with the obese PCOS, and this is what I came across, that definitely compared to lean PCOS, the obese PCOS have more ovulatory dysfunction. And yes, those lean PCOS who have ovulatory dysfunction are the most difficult to treat, but they are less. Remember, we are not seeing that many of them because they conceive naturally, they are okay. But the obese PCOS with ovulatory problems are the ones which we come across and we need to treat them. Then metabolic challenges in women. I think if you look at impaired glucose tolerance, the type 2 diabetes, and the metabolic syndrome of hyperlipidemia, etc., the chronic inflammatory diseases which occur because of the chronic inflammation, all this, the odds ratio in women with PCOS is much higher compared to women without. And the relative risk for conversion to impaired glucose tolerance and non-insulin dependent diabetic is over a 6-year period the study was done, is definitely higher in PCOS patient, and you can see the incidence increases as the BMI increases. So we need to be really aware of this. Risk of stroke is higher in PCOS women. Coronary heart disease, higher in PCOS women. You can see the odds ratio going on the other side. The increased obstetrical complications, gestational diabetes, preeclampsia, very preterm births. I mean, with our modern management, we are definitely taking care of them. But these are the problems, and these are exacerbated by obesity. Malignancies, I think we need to remember that 2.7-fold increase in developing endometrial cancers, the possible risk of ovarian cancer in women with PCOS. Overall, the risk of ovarian cancer is reduced with the use of OC pills, and no association of PCOS and breast cancer is seen. Mental health, it's become a big issue. The other day I was at a conference, at an advisory board meeting, and one of the girls said, oh, there are mental issues with PCOS. I have PCOS, but I don't have any mental issues. I think there's a lot of denial also, because you feel you're fine, you're normal, but it has been shown because of the underlying pathophysiology, there's an increased risk of depressive symptoms in women with PCOS independent of BMI. So, we think that only because of the body image, because of obesity, but this is an independent finding. Increased prevalence of general anxiety. Increase in mean anxiety scores in women with PCOS compared to controls, and reduced quality of life compared to women without PCOS. We've never really looked at these aspects of PCOS, and I think it's time that we give attention to our women who have PCOS. We treat them, we give them a baby, and we send them back home. I think we really need to look at them. So treatment approaches, definitely lifestyle, healthy eating, and physical activity. That is what we tell everybody. Can you imagine how much depression you put them into? Because they've tried all this. They have tried all this. So yes, the metabolic dysfunction can be really be tackled by 5 to 10% weight loss in women with obesity. And what do we offer them today? Oral contraceptive pills and metformin. Let's go to hyperandrogenism. We have anti-androgens. And for fertility indications, I'm going to talk a little bit on this slide. We have ovulation-inducing agents. Today, there is no question letrozole is the first drug of choice in PCOS. We start with 5 milligrams per day from day 3 to day 6, 7, or you can even start from day 2 to day 6, there's no problem. If my AMH is really high, more than 7, I would start with 2.5, looking at the antral follicle count. So I think what you need to do is look at the antral follicle count, look at her AMH, and look at her BMI. Because if the BMI is high, you may need a little higher dose. But always be cautious. In a PCOS patient, don't do planned intercourse without follicular monitoring. Please do follicular monitoring, because this girl may hyperstimulate anytime. And then you may have those sextuplets which were born in America. They were all the result of ovulation-inducing drugs, not of IVF, because we don't put back so many embryos. So these drugs have to be used very carefully, very judiciously. So follicular monitoring is a must when you do PCOS ovulation induction. And gonadotropins. Gonadotropins is the second drug of choice. Yeah, I normally, you can start it at a dose of 50 international units or 75 international units daily. And of course with follicular monitoring. And when she ovulates, I would prefer to combine it with an IUI because it becomes a little better cost effective. But what the international guidelines say is that you can use gonadotropins with just planned intercourse to get them pregnant. In the international guidelines, there is no role of IUI. They say letrozole or clomiphene citrate, metformin, gonadotropins, and straight you go on to IVF. So there's absolutely no role of IUI. But in our country, let's be practical. We like to do CC, letrozole, ovulation induction and planned intercourse. If that doesn't work, usually I jump to IUI. IUI with letrozole, gonadotropin combination. So letrozole for the first 5 days and then gonadotropin every day. Or you can go for gonadotropin only, the low dose gonadotropin. There are certain patients which require gonadotropins for even day 28 and they'll ovulate on that day. That is the chronic low dose. You give 75 international units for 15 days and then you step up the dose. So I have, in my 30 years of practice, I have seen anything and everything being used. And whatever, it works. It works for some people. But I think if we follow the standard practice, it would be what is the norm. So you can use gonadotropins with IUI. Try 3 or 4 cycles if the patient is younger than 35. But otherwise, IVF is the treatment of choice for her because you can give her a single healthy baby with IVF. So remember this, you start ovulation-inducing drugs, you do IUI. If it doesn't work out, please offer her IVF sooner rather than later. Now I come to the very different aspect, which is the benefit of weight loss. There are very different things which are available. I know I've been fighting weight loss all my life. I yo-yo, you see me. Sometimes Nandita's thin, sometimes Nandita's fat. And it's a problem with all PCOS or obesity patients. And weight loss actually creates something very wonderful and improves the clinical features and long-term metabolic health in women with PCOS. Insulin levels are lowered, decreased insulin resistance, decreased androgen levels, menstrual cyclicity, ovulation, fertility is improved, psychological outcome is improved, CVD factors and T2D is reduced, reduction in hirsutism, acne and skin affection. Androgen levels are reduced. We know that in PCOS whenever there's weight loss. Then insulin levels and weight loss in women with PCOS, we know that it reduces. If you see, the black line is of the PCOS and the blue line is without PCOS. And the PCOS patients, the insulin levels really drop very dramatically. Now, there is a new drug which we are all very excited about, and this is what I wanted to talk about. This is the glucagon-like peptide 1 receptor agonist. See, it's one of the peptide hormones involved in appetite regulation. It is primarily produced in the intestinal Langham cells and the hindbrain neurons and secreted into the circulation a few minutes after food ingestion. The endogenous GLP-1's role is to stimulate insulin, suppress glucagon secretion, promote glucose disposal, and reduce appetite and food intake. Can you imagine this role? And the GPL-1's action in the hypothalamus and digestive system result in increased feeling of satiety, reduced appetite. These two things definitely facilitate weight loss through reduced energy intake. And also it reduces your craving for food, craving for carbohydrates, craving for sweets, craving for fatty food. So I think it's a wonderful peptide hormone. And we have an agonist molecule, the liraglutide. Liraglutide is very much available in the US market and it's available in India. The only catch here is that it has not been approved for obesity and PCOS yet. But we are using metformin. Metformin just got approval after 10 years of usage. So yes, the endocrinologist and the obesity surgeons and the bariatric surgeons are using it. So I thought, why not introduce it to our gynecologist? Because this is something that can help our patients. So liraglutide is a subcutaneous injection which is available now. It's a daily injection, and you can start with the dose of 0.6. The ideal dose for weight loss is 3 milligrams. What is approved is 1.2 milligrams because it's used as for diabetes. And what was seen was liraglutide treatment was associated with improved bleeding ratio compared to placebo-treated women, decrease in testosterone, trend towards lower ovarian volume, and a mean weight loss of 5.2 kilos from baseline. So there was a study which was done, which was, the liraglutide. Then there's a semaglutide, which is another drug which is available now in the oral form. And there is a semaglutide, which is a weekly injection. Now, all these, the weekly injection is not available in India. The oral one is available in India. The weekly injection gives 15 to 20% weight loss. The oral one is supposed to give 15% weight loss, and liraglutide gives about 10% weight loss. So it is an amazing drug. The side effects are nausea, vomiting, all GI disturbances at the moment. There is nothing that has been, put forward that because of the other drugs which had the side effect, yes, give me 2 minutes more. The other drugs which had the side effect of depression, anxiety, suicidal tendencies is not there in this drug. And this is something wonderful which is today available to our girls. And I think along with lifestyle modification and a calorie deficient diet of just 1500 calories, you can really achieve. So weight loss with liraglutide increases IVF pregnancy rates, preconception intervention with low-dose liraglutide added to metformin aided in increasing the pregnancy rate by embryo transfer and cumulative pregnancy rates in infertile women with obesity and PCOS. So weight loss prior to either spontaneous conception or conception by IVF in obese women is recommended by all international guidelines. In fact, in UK, they don't even take them in the NHS unless you've lost weight. I have a lot of patients who do IVF and they say, okay, before before the FET, should I lose weight, madam? And remember one thing, liraglutide cannot be used during pregnancy and lactation. So if you're going to use the drug, you have to give a 1-month washout period. That's the only downside for us IVF specialists. And maybe she'll conceive naturally in her waiting period. But you have to warn them that liraglutide, there are no studies on pregnant women, and in animals it has shown to be getting thyroid medullary cancers, but nothing in humans at all. There's another new drug which I came across, SGLT2, that is sodium glucose co-transporter molecule, which is also an anti-diabetic drug. And can you believe it? It acts on all these things. Insulin release, inhibits glucose and sodium resorption, promotes glucose urine excretion, decreases gluconeogenesis, enhances lipolysis, reduces fat liver tissue, decreases blood glucose level and blood pressure, increases insulin sensitivity, increases glucose uptake, reduces visceral adipose tissue, promotes weight loss. I mean, these are the drugs which are being used by the endocrinologists, which are being used by diabetologists. The only thing is this drug is not yet approved. It has a lot of side effects and we are waiting for its safety profile to come in. So until more research confirms the positive metabolic effect of these drugs, SGLT2 inhibitors in PCOS patients, the mainstream treatment option is lifestyle intervention, metformin and oral contraceptives. But remember one thing, that this lifestyle metformin oral does not successfully address long-term cardiometabolic consequences of PCOS. So maybe, the ones which I talked about before, GLP and these could, because of their mode of action, may emerge as the potential new treatment for PCOS, but we have to wait for some time. The GLP-1 agonists are definitely being promoted. Their safety profile has come up, and they have been there since 2010. So they are slowly coming in for obesity. So, but this molecule, when I read about it, I was a little worried when I saw all the side effects. So we need to get the safety profile of this. This is known as Forxiga, which is available in the market right now, but I wouldn't advise it as a responsible person. The economic burden of treating, can you believe it? It's $4.36 billion in US of PCOS patients. And we have such a high preponderance of PCOS. So it's not only fertility, but it's long-term consequences, and we need to wake up and address the situation. So friends, I'm going to end my talk with just this last slide, which was from the international guidelines created by Kripos, ESHRE, ASRM in 2018. As I said before, letrozole, clomiphene, metformin, gonadotropins. And if that doesn't work, you go to gonadotropins and laparoscopic ovarian surgery, which is the second line of management. If that doesn't work, the third line is IVF. So I feel today what we have with us is the letrozole, clomiphene, metformin, gonadotropin, and IUI IVF. This is how we should go, and not waste time and not waste their age. So PCOS is the most common endocrine disorder in females with a high prevalence, no medication approved, pathophysiology is not clearly understood. PCOS and obesity are intricately linked. Obesity continues and exacerbates the complications of PCOS. Weight loss in women with obesity is recommended as the first line of treatment. Diet and weight loss has proven beneficial. Anti-obesity treatment, including medications and bariatric surgery, should be considered for PCOS after an assessment of the risk syndrome. But something new which I want to leave you with a food for thought is genomics. Precision medicine is coming in PCOS. And I talked about GWAS, the Genome-Wide Association of Genes, which is being done for PCOS. So with this precision medicine in PCOS, we are going to predict PCOS, we are going to treat PCOS, and actually the women who come and say, can you cure me of PCOS? And probably 5 years down the line, we will cure her of PCOS with precision medicine and with this genetics. We can no longer say that, oh my God, you have PCOS, it's lifelong, you have to take this drug. You have to be treated lifelong. So things are changing, and I'm really happy to be in this era where I can offer these kind of treatments to patients. Thank you. Thank you very much.
Thank you, madam. Thank you for this enlightening talk on a very important concept of this obesity in relation to PCOS, and we have to look at her down the lane, not just the fertility alone, should be looked into the lifestyle of everything. And a very interesting fact you have brought about the liraglutide, and I'm very happy that you have insisted on the international guidelines, which is very important for the students here to take home message to treat the PCOS right as a guidelines. That is very important. And very interestingly, you have talked about the latest liraglutide, which is a very important concept that we should work with the endocrinologist to plan her treatment of obesity correction, which is very important to have a good fertility outcome. I just have only one question. Do this drug have an effect on the truncal obesity? Because we are looking more of a thin PCOS, a waist-hip ratio is very important in the PCOS. Does it have a role of a lean PCOS with a waist-hip ratio which is altered?
See, most of the studies have been done on, they've recommended this drug at a BMI which is higher. So I don't know whether it'll have an effect on the lean PCOS. But personally, I feel looking at its profile, not the liraglutide, but the other one, where if you have that, you catch that lean PCOS who has metabolic syndrome. I think you have to identify the subgroup of patients who are lean with metabolic syndrome. They will benefit from this. The metabolic syndrome, the diabetes, the insulin resistance is very important where these, for this drug, I feel.
Thank you. So, thank you, madam. We'll move on to the next talk.